Welcome, everyone. Thank you for joining us. We are excited to have you participate in our case discussion. My name is Dr. Bed, a hematologist at the University of Texas, Dallas. Today, I'm honored to introduce our esteemed guest speaker, Dr. Berentsen. He graduated back in 1973 from the University of Bergen, Norway, and earned his PhD thesis in 2004 titled Primary Chronic Cold Agglutination Disease. And his clinical training includes internal medicine at Hagsank Hospital at Stavanger Hospital. And he had a hematology training at St. Olav University Trondheim and Haukeland University Hospital in Bergen. So Dr. Berentsen has held position as a consultant hematologist at various hospitals and was an associate professor at the University of Bergen from 2004 to 2016. Currently, he serves as a consultant hematologist and senior researcher at the Department of Research and Innovation, Hagsank Hospital. So Dr. Berentsen authored numerous PubMed reference origin and review articles, as well as the major textbook chapters, and he led most of the cold agglutinin disease trials, and he also authored most studies on complement inhibition. So Dr. Berentsen has delivered invited lectures at various international meetings, including ASH, and he's been the author of the cold agglutinin session in UpToDate. Without further delay, let's extend more welcome to Dr. Berentsen as we kick off the event.
Yeah, good morning, everyone. Thank you for the introduction, and thank you for inviting me, which is an honor, and I'm also sure we will have a good discussion. I'd like to start with some definitions. By cold agglutinins, we mean cold reactive autoantibodies that can agglutinate red blood cells. And today, cold agglutinin disease is defined as a cold agglutinin-mediated autoimmune hemolytic anemia with no underlying clinical disease. Of course, there is an underlying pathogenesis, but no underlying clinical disease. That's distinct from cold agglutinin syndrome, which we today define as a similar syndrome caused by a definite clinical disease, another clinical disease. We will also have a look at the diagnostic workup. It often starts with the patients having anemia, and you have to verify that the anemia is a hemolytic anemia. And a blood smear microscopy is also useful, which will often show the agglutinates, which we will see in a moment. Next step is a direct antiglobulin test, DUT. And if it's positive, you have to do a monospecific DUT. I think in the US, monospecific DUT usually means testing with antibodies against IgG and C3d. In Europe, we also add C3c and IgA and IgN. Maybe you do that in some centers in the United States too. That will often make it possible to differentiate between warm antibody autoimmune hemolytica or the cold antibody type, or in rare cases, the mixed type. If the monospecific DUT is positive for C3d with or without IgG, you have to do a cold agglutinin titer. And if the titer is high, defined as at least 64 or 1 to 64, usually much higher, it will usually be a cold agglutinin disease or cold agglutinin syndrome. And then you will have to distinguish between disease and secondary syndrome. And if it's cold agglutinin disease, we should do a bone marrow biopsy and the bone marrow flow cytometry and the serum protein electrophoresis. What's also important is handling of samples. The most important details of handling of samples is the second row in this table. If you are going to look at cold agglutinin titer at the thermal amplitude, or are going to do immunoglobulin quantification or electrophoresis or immune fixation, Serum or plasma must be drawn into pre-warm tubes and placed in a warming cabinet or a water bath until serum has been removed from the clot or plasma has been removed from the cells. After that, the sample can be handled at room temperature. And those precautions are essential if we want to detect all cases and if we want to monitor the patients.
This is a 72-year-old female patient, presented with the chronic fatigue and history of macrocytic anemia since 2018. She had a hemoglobin of 9, MCV 01 of 5, unremarkable CBC otherwise. She had an extensive workup for her anemia, including GI, nutrition, and vital workup. And around 2019, she had a bone marrow biopsy that showed 70% cellularity. There was a very minimal dyspoiesis, normal cytogenetics with normal MDS fish panel, and she had the unremarkable next generation sequencing. She was started by erythropoietin injections by outside hematologist, and she did not have really a good response, and she started to requiring transfusions every 4 to 6 months, especially during the cold weathers. And you can see the peripheral smear, the agglutinations of the red cells. And then when she came in, we repeated her bone marrow biopsy. Again, there was no evidence of MDS. And she had clear erythroid hyperplasia with red blood cell agglutination. And flow cytometry showed very minute B cell population, 0.05%, with unremarkable cytogenetics and MDS workup, including NGS. Her blood work showed hemoglobin 7 with MCV 115, reticount 7%, LDH 450, with low haptoglobin, elevated ferritin level. Her serum free light chain was abnormal with the free light chain ratio of 4.6, but otherwise SPEP was unremarkable with a normal immunoglobulin level. She had a DAT testing positive for C3D, and then cold agglutinin titer was 1024 at 4 Celsius. We did tested her for mycoplasma IgM. That was unremarkable. Her thermal amplitude was positive for agglutination at 30 Celsius and room temperature. And she also had the CAT scan of neck, chest, abdomen, pelvis. That was unremarkable. So the question we have to Dr. Berentsen, the first 3 questions: what does the standard evaluation involve for patient with cold agglutinin disease? How much role of cold agglutinin titer and thermal amplitude do we need to give? And then the second question, in cold agglutinin disease, where does hemolysis occurs as opposed to warm agglutinin disease? And the third is, how do you interpret that minor flow cytometry findings, or any patient presenting with very subtle, very small population of B cells? And does it matter when you determine the treatment approach for B cell directed therapies for cold agglutinin disease?
Thank you. In the following slides, I will try to answer those 3 questions. First, my comment will be that the diagnostic workup was very adequate. It was a good diagnostic workup, and this was without any doubt a patient with cold agglutinin disease or primary cold agglutinin disease. It has been increasingly recognized and increasingly accepted that cold agglutinin disease is a bone marrow lymphoproliferative disorder, a distinct type of lymphoproliferative disorder that produces cold agglutinin. And from 2022, that entity is recognized as a separate entity, as a distinct entity in the WHO classification of hematolymphoid neoplasms. But it's not considered to be a malignant lymphoma. And here you can see the typical histologic appearance, but in some cases it may be very tiny, very difficult to see, and often the bone marrow biopsy is dominated by the compensatory hematopoiesis, and that makes the lymphoproliferative changes even more difficult to identify. Yes, and that lymphoproliferative disorder produces a cold agglutinin, a monoclonal cold agglutinin, usually of the IgM type, and you can see the results in the blood smear, the agglutination, very similar to the picture you showed us from patient 1. And to be observed, this process that far is not complement mediated. But the antigen-antibody complex will activate complement protein complex C1, and C1s gets activated, and the classical complement activating pathway will be triggered. And that makes the red blood cells opsonized with complement protein fragment C3b. And the opsonized red cells are phagocytosed mainly in the liver, called extravascular hemolysis. To a smaller degree, as shown in the left parts of the and the right parts of the panel, C3b can also trigger the terminal complement pathway by splitting of C5, and the red cells can be covered with the MAC or C3b29, which results in intravascular hemolysis. That occurs to a lesser extent, and so the answer to one of the questions is that hemolysis mainly occurs in the liver. There was also a question about the diagnostic criteria for cold agglutinin disease. Those are a chronic hemolysis, a polyspecific DAT positive, monospecific DAT strongly positive for complement C3d, cold agglutinin titer at least 64 at 4 degrees Celsius, but usually much higher, as in this patient. No overt malignant disease or relevant infection. That's the required criteria. There are also some confirmatory criteria that are not required for diagnosis, mainly because of sensitivity issues. Often it will be possible to identify the monoclonal IgM kappa by electrophoresis. That was not possible in this patient, but at least the kappa lambda ratio was elevated, so there was a hint. And the ratio between kappa and lambda positive B cells in the bone marrow aspirate should be more than 3.5. To be noted, this is not the serum kappa lambda ratio, but the ratio in the in bone marrow aspirate. I think here even the kappa lambda ratio in serum was slightly elevated, and often we will see the cold agglutinin associated LPD by histopathology in the bone marrow, which was not the case in this patient and is relatively often not the case. To be noted, diagnosing that cold agglutinin associated lymphoproliferative bone marrow disorder is not always straightforward. We studied bone marrow biopsies in, I think it was 180 patients with cold agglutinin disease, and those biopsies were examined in a decentralized way, examined by local pathologists, but we encouraged biopsy review by centralized pathology labs, particularly experienced in diagnosing cold agglutinin disease. And here you will see the results. The red columns are the results from the centralized examinations, and you see the frequency of diagnosing that cold agglutinin associated bone marrow lymphoproliferative disorder increased manifold when it was examined by experienced biologists, and the number of patients with no signs of LPD went down, and also the number of patients diagnosed with other types of low-grade non-Hodgkin lymphomas went down.
Yeah, the fourth question, when a patient with cold agglutinin disease experiences constitutional symptoms, despite having very relatively mild anemia, what is your management strategy? The following is, what factors guide your decision on when to initiate treatment for cold agglutinin disease?
Yes, thank you. I will give an outline of my answer. The clinical features of cold agglutinin disease are hemolytic anemia, and often also cold-induced circulatory symptoms, mainly acrocyanosis, often even Raynaud-like symptoms. I think such symptoms are found in between 40 and 90% of the cases. That might be climate dependent. I think in Norway, the correct answer is closer to 90%. In Texas, I guess it may be closer to 40%. Fatigue is very common and not only related to the level of anemia, because the complement activation itself produces fatigue by liberating soluble complement split products that have pro-inflammatory properties and can cause fatigue. So we can see patients with mild anemia, but considerable fatigue. About half of the patients or more have exacerbations in febrile illness or after major trauma or major surgery. About 50% or somewhat less has been transfused at some time. There is an elevated risk of thrombosis, but in most patients, the risk is relatively slightly elevated, and the mortality is probably slightly increased. This is some details about the level of anemia. If we define severe anemia as below 8 grams per deciliter, 1/4 of the patients have severe anemia. About 1/3 of the patients have moderate anemia, defined as between 8 and 10. About 1/4 have mild anemia, defined as between 10 and lower limit of normal. And the minority of patients have compensated hemolysis with no anemia, because the bone marrow compensation is good. So that was not a direct answer to your questions, but it indicates that today, when cold agglutinin disease is a treatable disease, I would treat patients with significant anemia and patients with significant fatigue, even if the anemia is mild, and patients with disabling cold-induced circulatory symptoms.
Great. Thank you. So what is your first line? So we will go over this 4 questions. I will read it, and then we will go over it with Dr. Berentsen. What's your first line treatment approach for cold agglutinin disease? Under what circumstances would you consider adding bendamustine to rituximab in cold agglutinin disease treatment? How do you evaluate response rate, and what is the anticipated time frame for response to rituximab and rituximab bendamustine therapy? When do you consider C5 inhibitor therapy in combination with C1 inhibitor and for cold agglutinin disease? And how do you manage the preoperative cold agglutinin disease patient if they require either elective or emergent surgery? So we will start with this.
Yes, and this is an overview of therapy. First, it should be observed that drug therapy is not always required. As I already mentioned, patients with mild clinical disease have not been shown to profit from therapy. And second, do not use corticosteroids, because the response rate is very poor. And often, if in the few patients who do respond, they often require very high doses, and steroids are toxic drugs in high doses. And splenectomy is ineffective, because most of the hemolysis occurs in the liver. Then we have 2 major groups of therapy. We can direct the therapy against the pathogenic B-cell clone. The classic version is rituximab monotherapy, and then we have the combination therapies with rituximab, and also proteasome inhibitors, bortezomib, have some efficacy, and then BTKE inhibitors are very promising, but still investigational. Then in the second group, we have the complement-directed therapies. First and foremost, sutimlimab, which is a monoclonal antibody, a C1s inhibitor that is established and well investigated and is approved in the US and Europe and in Japan. And we also have the C3 inhibitor, a peptide called pegcetacoplan, which is still investigational. Some more details about the B-cell directed therapies. Rituximab monotherapy should be given for 4 cycles. It does not have an impressive response rate, that should be noted. It was the first therapy shown to be effective in a prospective trial. And back in 2004, we were very proud of that trial. And it was the first trial, it was the first treatment shown to be really effective for cold agglutinin disease. But I think today we have better options than rituximab monotherapy for most patients. Almost all responses are partial, and the median response duration is disappointingly short. But patients can often be successfully retreated when they relapse. And the therapy is, as all of you know, usually well tolerated. Bendamustine plus rituximab should be given for 4 cycles. And I think we should stop after 4 cycles for reasons that I can come back to. The response rate is very high, and the frequency of complete remissions is impressive, in my opinion. The median response duration is very long, as I will show. In my opinion, the toxicity is acceptable in most patients. 11% infection with or without neutropenia. In some patients without neutropenia, and the infections were readily treatable, at least in the prospective trial. And it appears to be relatively safe with regard to late malignancies. For both therapy, however, the time to response and even more the time to best response can be very long in some patients. And you will see the figures far down at the slides. So the time to best response can be up to 30 months for some patients. So patients who do respond to bendamustine plus rituximab has an excellent prognosis for staying in remissions for many years. The median the median relapse rate was not reached after 84 months. And then we have the complement-directed therapies. And here I have tried to illustrate the points of attack in the complement cascade. And as I mentioned, sutimlimab or Enjaymo attacks at the C1s level, very upstream. Pegcetacoplan also attacks in the classical activation pathway, but eculizumab attacks, as you know from PNA patients, in the terminal complement cascade. And as you will see from the cartoon, and also supported by studies, I would say that this is a wrong point of attack. That's just one of the sutimlimab studies. As you will see, this was a randomized study, and patients who did not respond were given active therapy after 26 weeks. And in the left panel, you see the effect on hemoglobin level. Hemoglobin raised very rapidly in the patients who received active treatment up to normal or so slightly subnormal levels. but nothing happened in the placebo group. And when the placebo patients received active treatment, the same happened as in the treatment group. So it's a wonderful drug for the hemolytic anemia. In the right panel, you will see the results of bilirubin, which tells us exactly the same. The initial effect is very rapid. The drawback of this drug, that's okay. The drawback of this drug, in addition to the costs, is that because the cold-induced circulatory symptoms are not complement mediated, this will not work against the agglutination or the Raynaud phenomena. And there was also a question about complement inhibition and major surgery. There are not very much data, but there are two good case reports. The first one is back from 2017, showing that even sutimlimab was eculizumab was effective against exacerbations induced by cardiac surgery. The explanation for that is that in acute exacerbations, also the terminal complement pathway is activated, and eculizumab efficiently blocked the terminal complement pathway responsible for the intravascular parts of the hemolysis. A more recent case report show that sutimlimab was also active in prophylaxing against exacerbation after major surgery. That too was a patient undergoing cardiac surgery. Of course, anyway, we try to avoid hypothermia. There was also a question before we start on case 2. There was also a question when do you combine C1s inhibition and C5 inhibition, and my answer would be I have never done that, and I will do it. I will almost never do it, because the complement inhibition is achieved very efficiently with just the C1s inhibitor.
Great points. We have a couple questions, but we will ask at the end. So we will start with the second case. This is a 61-year-old Caucasian male, has noted hemoglobin of 9, MCV 130 with positive DAT for IgG and complement C3d. A year later, he was found to have a hemoglobin of 4.3 with unremarkable CVC otherwise. Retic count was 62% and LDH of 2,700, where he was given a 1 unit of blood and then started the prednisone along with rituximab for mixed autoimmune hemolytic anemia. Hemoglobin improved to 10.6, retic count decreased to 18%, LDH norm kind of came down to 700. He did not have any cold agglutinin titer at the time. So he was diagnosed with mixed autoimmune hemolytic anemia. He stayed on high-dose prednisone, 1 milligram per kilogram, and then CELCEP started, but when they tried to wean off the prednisone, he relapsed and then required transfusion. So he was given the IV Cytoxan, and then he had a splenectomy with the concern of this worm component. He had an unremarkable CAT scan, and so he was basically treated as a refractory mixed autoimmune hemolytic anemia. He was given Imuran and danazole in addition to Cytoxan. He did not have any response. So then his repeat bone marrow biopsy showed hypercellular marrow with erythroid hyperplasia. There was no morphologic abnormality. And then he had a normal male cytogenetics and no PNH clone or disease. He had a normal NGS, and his cold agglutinin titer was less than 32. So he did not have the terminal amplitude. So we repeated the bone marrow, and it showed the 80% cellularity. Again, the erythrocytic hyperplasia with no lymphoproliferative disorder component. He had an unremarkable flow, NGS, and cytogenetics with deletion deletion chromosome Y. It was unremarkable NGS otherwise. And then he had a peripheral smear that showed elliptocytosis, reticulocytosis, and there was no features of spherocytes or agglutination or xerocytosis. He was on prednisone when he presented to us. And then with this low hemoglobin and prominent hemolysis with low haptoglobin and LDH of 340 with indirect bilirubin of 2, we tested him for DAT, again came back positive for IgG and complement. He had the unremarkable TSH and nutritional panel. His ferritin was pretty high because of his transfusion history. And then, so we did tested him for other viral because of his immune suppressed condition. EBV, CMV was unremarkable. He had a little bit free light chain ratio increase, but otherwise normal SPEP. And his germline testing showed this alpha allele mutation. I think it was heterozygous, as well as this SPA2, the SPTA1 exon 40 heterozygous mutation. So the question is going to be, how do you describe the refractiveness in relation to most immune modulators? And what is the distinction between treatment refractiveness and disease relapse in the context of cold agglutinin disease? And when do you make that distinction? How many months after being responded or not responded? The third question is, what is the prevalence of this alpha allele or SPTA exon mutation in general population? This is two different genes. And what is your approach when managing patients with refractory cold agglutinin disease? And when do you contemplate the utilization of long-term steroids for mixed autoimmune hemolytic anemia?
Well, I think I can try to answer some of the questions first, and then come back with some overall comments on that patient. And for sure, it's a very difficult case, a complex case, a particular case, and I have not many definitive answers. First, the use of immune suppressants in cold agglutinin disease, unspecific immune suppressions like azathioprine and Cellcept and whatsoever. We have rather little data, but we had some patients in descriptive studies of cold agglutinin disease treated with those drugs. The numbers were small, but the response data were very poor. So those drugs are not encouraged in cold agglutinin disease. For mixed antibody autoimmune hemolytic anemia, we don't know. And I have not mentioned anything on my slides about splenectomy. As I said, for cold agglutinin disease, it's discouraged because hemolysis takes place mainly in the liver. For mixed autoimmune hemolytic anemia, we don't know very much about the effect of splenectomy. My very good friend and colleague Vilma Baccellini in Milan, Italy, has seen a fair number of patients with the mixed type, and she, in her opinion, splenectomy should be discouraged. She has not seen any patients who profited from splenectomy. Then, to answer one of the questions, I would like to say something about autoimmune hemolytic anemia with DAT positive for IgG plus C3d, which was the case in this patient. The conditions that may explain that combinations can be warm antibody autoimmune hemolytica with complement activation. And I think that will be the most common cause. The next most common cause will be CAD or CAS. as 20% of patients with cold agglutinin disease are weakly positive for IgG, in addition to the strong positivity for C3d. Don't ask me why they may be weakly positive for IgG, because I don't know, and I think no one knows. And then the least frequent condition will be mixed autoimmune hemolytic anemia. There are not a full consensus in the literature of the criteria for mixed autoimmune hemolytic anemia, but at least if we apply strict criteria that I can come back to, that is a very rare entity. So here are the criteria for mixed autoimmune hemolytic anemia. Monospecific DAT, strongly positive for IgG and strongly positive for C3d. Cold agglutinin should be demonstrable in a high titer, which was probably not the case in this patient. And there should be warm active antibody in serum. That can be determined, for example, by the indirect antiglobulin test, or so-called indirect CUMS, which should be positive for IgG at 37 degrees, at least according to one author and one good study. That should be a criteria. So we will come back to the handling of samples once more, because I don't know how the samples were handled in this patient. But of note, a cold agglutinin titer may be missed if there is has not been an adequate handling of the samples. I am not an expert in congenital hemolytic anemias, so here are much that I don't know. But as you know, hereditary xerocytosis, elliptocytosis, and pyropoikilocytosis are caused by mutations in the genes for cytoskeleton proteins, including the SPT1 mutations. I don't know the frequencies of these mutations, but I think they are highly variable, with geographic variations and racial and race-related variations, racial variations. For example, hereditary xerocytosis is rather frequent in my country, while it's rare in many other countries. On the other hand, elliptocytosis is very frequent in Southeast Asia, while it's very rare in the Scandinavian countries. So I think the distribution of those genes must be highly variable. So I think that's the best answer I can give to the answer about frequencies. And then refractory cold agglutinin disease. If you mean refractory to the first line of treatment, patients who are refractory to B-cell directed therapies like bendamustine plus rituximab, I think at least if the hemolytic anemia is the main feature, sutimlimab is the best second-line treatment we have. On the other hand, a few patients may be refractory to sutimlimab. Then I would do a diagnostic re-evaluation, and if I maintain the diagnosis of cold agglutinin disease, I think bendamustine plus rituximab is the best second-line therapy we have, if the patient is able to tolerate chemoimmunotherapy. If we are thinking of what is the last resort, what is the treatment for multi-refractory patients, I don't know for sure, and I think no one knows for sure, but a promising option is bortezomib combinations, not bortezomib monotherapy, because that is not very efficient, but I think we would expect good results of bortezomib in combinations, for example, with rituximab and dexamethasone.
Yeah, Dr. Berentsen, have you ever considered obinutuzumab rather than the rituximab if the patient exposed to rituximab within the 6 months to combine with the bendamustine?
No, I haven't, and I don't know if anyone else has.
Yeah, this patient, we treated this patient with bendamustine and obinutuzumab because he was maintained on every 6 months rituximab, high dose rituximab, and I felt if I will give another round of rituximab, it may not be effective. So we treated him with obinutuzumab and bendamustine with 4 cycles, and he's been 7 months now in remission. So I think there are a couple questions that I have, and then we can circle back with the group. The first question is that you did elegantly show the benefit of inhibiting the complement pathway by potentially C3 inhibitors. So the question is, rather than or other than IV versus sub-Q pump administration mode differences, do you anticipate that pegcetacoplan will be more effective because basically you are also inhibiting the alternative and lectin pathway activation? Is that something that is favorable to do, or do you think stimlimab should be only the one that should be used in cold agglutinin because we only can target the classical pathway, which is a culprit for the hemolysis?
Of course, I don't know for sure, but I have always implicated the classical pathway as the culprit. But of course, there may be a contribution by the alternative pathway because, as all of us know, the alternative pathway is always slightly activated to some degree. So I wouldn't exclude the possibility of still improved effects of pegcetacoplan. After all, in many patients, sutimlimab does not fully normalize the hemoglobin level, but it often reaches slightly subnormal levels. So pegcetacoplan may be a good idea, and I think the pegcetacoplan studies, we have a phase 3 pegcetacoplan studies ongoing, and it's a very exciting study. And if it turns out to result in a full normalization of hemoglobin levels and complete blockage of hemolysis, that may be explained by the alternative pathway.
Okay. The other question is, you mentioned about the hemolysis prominent patient profiles versus the Raynaud phenomenon or acrocyanotic patient profiles. And do you decide based on their symptoms when you are deciding the first line whether you would prefer BR or stimlimab? Stimlimab, maybe hemolysis is more prominent, or the other way around, if the symptoms are more prominent, you would go with the BR. Do you have any preferential with that symptoms presentations?
I think there should be preferences and individualization, because for my part, I tend to use more bendamustine rituximab than you use in the United States at the moment, because I think sutimlimab has been a very much used therapy in the United States because it's the approved therapy. I still use bendamustine plus rituximab in many patients. And I think it will influence the choice of therapy, because if the patient has very prominent circulatory symptoms, I would not treat with complement inhibition, at least not in the first line.
Oh, okay. The following question is that when you initiate a stimlimab, I'm pretty sure you are making the mutual agreement with the patient when to consider to wean off. Do you anticipate that at some point you will have the possibility to wean these people? I mean, we don't do that for PNH patients for complement inhibition, but we do for some of our HUS patients. That's also complement mediated. So do you have any sense that we may be able to, in the future, I know we don't have any trial at the moment, discontinuation trials or discontinuation approaches, because this medication is pretty expensive, and this disease is not life-threatening condition as PNH. How do you counsel this to your patient when you are saying this is a lifelong medication? Or do you anticipate we will have more data in the near future for weaning off?
I think for the last question, yes, I think we will have more data in the future. But otherwise, it's a very good question, a very interesting question. And I'm very excited to see the results of other observation of the patients who have participated in the trials. It is, of course, as you say, this is a very different disease from PNH, even if both are complement-mediated hemolytic diseases. And it is not quite impossible that complement inhibition may do something to the lymphoproliferative bone marrow disorder. We don't know, but in theory, that might be possible. At the moment, most attempts of discontinuing sutimlimab have been disappointing. There are some publications, at least if you discontinue after 1 or 2 years, most patients will relapse. But there are a few reports. I think we have seen 3 cases of patients who have stayed on sutimlimab for 3 years or more with a good response, and then have discontinued, and at least after some months observation, they stay in remission. So we don't know, but these are very interesting prospects. Another way, besides an attempt of discontinuation under close observation, another option would be a transition to a B-cell directed therapy. I would think that if a patient has severe hemolysis, you give sutimlimab, you have the situation under control, you have stopped the hemolysis, but the patient will need continuation of therapy. It should be possible to change to B-cell directed therapy at this point to be able to discontinue sutimlimab. After all, as you say, it's very expensive, extremely expensive, and the patient has to receive those intravenous infusions every second week. So there are no studies, but I would consider transition to a B-cell directed therapy as a possible option.
Great. I mean, I know, do we have any questions, Selim?
Hey, Dr. Berentsen, thanks for joining us here. I'm really interested in hearing more about sutimlimab for mixed autoimmune hemolytic anemia, because we had a case a couple months ago, I think at Clements, of a mixed autoimmune hemolytic anemia that did respond to sutimlimab. I don't know if anyone remembers that case, but that was really really neat to see that. So has it been successfully used in mixed autoimmune hemolytic anemia? And then also, how do you transfuse these patients with cold agglutinin disease? Or when do you transfuse these patients?
Well, 2 good questions. And the first question, sutimlimab and mixed autoimmune hemolytic anemia. I think there are no published cases and definitely no studies, but often we consider complement activation as important in mixed autoimmune hemolytic anemia, and the mixed type is often difficult to treat and more severe than the warm antibody types. And according to the experience of some colleagues of mine, if a patient with mixed type has prominent cold agglutinin mediated clinical symptoms, it's often wise to treat them like CAD. So I'm not very surprised, and I think it's a very interesting observation. I would suggest you publish that observation. I think it's unique, and it may be very important. Then the next question: how do you transfuse, and when do you transfuse? Do you mean the patient? Do you mean patients with mixed type or with CAD?
I think both. You know, we've seen a lot of very severe hemolytic anemias, and often there's a reluctance to transfuse patients. But you know, I think they should be transfused.
Yes, I agree. They should be transfused when clearly indicated. But of course, patients with 7 or 8 grams per deciliter hemoglobin and a stable disease, not a rapid decline in hemoglobin levels, and no circulatory symptoms, they should be observed with other treatment. But of course, there are many patients who should be transfused, and you should not abstain from transfusion in a patient who really needs it. I think the most simple scenario is transfusion in cold agglutinin disease, because there is usually no problems in finding compatible donor erythrocytes. There may be problems, but usually there are not. So you do not have the compatibility problems. The patient should be kept warm, and in particular, the extremity used for transfusion should be kept warm. And even it's not hard evidence-based, we use an inline blood warmer. Of course, in the patients with mixed, you have to also take into account the usual precautions for warm antibody autoimmune hemolytica, which, as we all know, can be more difficult, but also are usually feasible to implement.
You did not mention about the plasma exchange for emergent surgeries. Is that something that you favor for cold agglutinin disease patients?
Another very good question. And if you had asked me 10 or 15 years ago, the answer would be yes. The theoretical rationale, the mechanistic rationale, is very good because this is usually an IgM-mediated disease, and 80% of IgM is located in the bloodstream, and it should be possible to remove it. And it has been described very favorable effect in many cases, so that could be tried, and I think it's still an option. When you ask me now, I would think that in most cases I would prefer sutimlimab as an emergency therapy, because it's evidence-based and the effect is very rapid.
Okay, got it. And there was a question, is there any genetic alterations? As we know, for HUS, 50% of them, they do have some sort of germline related mutations. Is there anything that defined in cold agglutinin disease?
I think, well, my answer would be usually not, or of very limited significance. I am aware of a few cases in which there are also cases in near family. So there is probably an inherited or germline component in a few patients. But by and large, we should view that as a non-hereditary disease.
Okay, got it.
Okay. There are some parallels to Waldenström. There is family disposition, but not very marked.
Okay. Fantastic. Thank you for everyone joining us, and we will adjourn here. Thank you, Dr. Berentsen. It's been a pleasure to meet you and hear your insights and discuss these cases. We look forward to host you again in the future for our complicated cold agglutinin patients. Thank you.
Oh, thank you. Yes, it was very nice to join the discussion and very nice to be able to discuss these very interesting questions. Thank you.